It's Thursday, the 14th of November, and it is 12 p.m. where I am in the lovely village of Sawtell in the east coast of Coffs Harbour, New South Wales. So welcome to everybody who's joining us for this fantastic session on high value, low carbon care and action. What is it and how you can get started? So I'm delighted to say that we have a fantastic array, a lineup of speakers from all around the country in multiple spheres and multiple disciplines. So it's going to be really exciting to hear from, we're going to go through the individual speakers. I'd like to start with an acknowledgement of country. And I want to recognise the Aboriginal and Torres Strait Islander people as the traditional custodians on the land of which we live and work, and acknowledge the sovereignty of the land that we call Australia and that has never been ceded. We commit to listening to and learning from the Aboriginal and Torres Strait Islander people about how we can better reflect Indigenous ways of being and knowing in our work. So that's the official acknowledgement, and I think those words ring true. I'd also like to say, from a personal level, I'm dialing in from Gambanya country, and it is, although I really feel now that I'm living in this country and with the people, it's so important to engage. And I can say that I have my own Aboriginal elder, Auntie B, and I'd like to put a shout out to Auntie B locally. And if you don't have an Aboriginal elder, you should definitely get one, because what we are doing is caring for country and caring for our patients. So welcome. I'd like to also have a shout out to Bupa Australia, the platinum sponsor of this year's Greening the Healthcare Sector Forum. And this support is enabled this virtual event to life. So absolute huge thanks to Bupa. I know there's public healthcare and there's private healthcare, and we really need to embrace both. And it's wonderful to have Bupa here as a fantastic supporter for these sessions. So a few housekeeping notes. At the bottom of your screen, you will notice the discussion forum. So we encourage you to share your reflections and your thoughts throughout the session and with other attendees in this forum. So the discussion forum will be for during the sessions. The second way of communicating is the Q&A. So please feel free to use this throughout the session, and we'll come to these questions at the end of the session. So the Q&A is for the end, and the discussion forum is during it. And a reminder, this session is being recorded and will be available via the platform for 4 months after the event. So we'd love to hear your thoughts and reflections in today's session. We'd encourage you to please tag us on @healthy_climate on Twitter, Health Alliance on LinkedIn. And I would say communication is one of the areas that we all find it can be challenging and time consuming, but getting that word out there, being here on today and getting the word out we talk about 7 different people that you can influence. So get out there and jump on social media, what you're hearing. So now the next few hours, you're going to hear a lot more about the different talks, which we'll go through. And we'll ask you to visit the poster room after this session, and you can access from the main lobby range of posters and videos, which have more great examples to provide of the high value care. So as we talked about today, we really are focusing on high value, low carbon care. And what is that? We all come from different stories. I won't go into a great detail about where I'm coming from, but I'll suffice to say, in terms of my journey, I started off as a GP. Now I'm an emergency physician. I work 1 day a week in ED and 1 day a week in the district for Mid-North Coast Local Health District as a sustainable healthcare lead. And how we bring that high value care into a district is really key. The other roles that we work in is with the new Sustainable ED team with New South Wales Ministry of Health and Net Zero team. So how to bring it in to where you work, because we're all coming from different areas. I'm sure we have nurses, doctors, other healthcare staff members, sustainability experts. And what does it mean for you today, wherever you are in Australia and beyond, and with the teams that you work with? So I think a key thing to remember is the audience that we're talking to, because to understand what high value, low carbon care, it can be complicated. And we have to bring it back to the person, the staff in front of you and the patients in front of you. So for a patient's point of view, high value care means that they're not admitted to hospital when they don't need to be, that they don't get the investigations that they do not, that they don't get expensive treatments that might make, bring on other problems and complications in their care. So it's around being patient-centered and finding what the value is for the patient. If we all come back to the patient from wherever we're practicing from, that will be a fantastic place to start. So value care is really a new area. There's high value, there's low value, there's value-based care, but it comes back to that patient in front of you and what they need. Carbon, again, what is that? What's carbon literacy? It's very difficult. I've got a book here by Mike Berners-Lee around the carbon footprint of everything, and it's a tricky area. So understanding, and you're already here, you've self-selected, so you're going to know a little bit about carbon literacy, but I would recommend that you start teaching it. Start talking, and you're probably already talking about it, and do some great courses in the Centre for Sustainable Healthcare in the UK. Some wonderful courses coming out all across Australia now with DEA, with the Australian Commission, with New South Wales Health, etc. So upskilling on what is carbon, and bringing it back, because that's hard to talk about when you come into a healthcare facility. But the other ways you can really think about this is, number one, as we said, the patient. Number two, from a clinical perspective, if you're on the ground, you want to have efficient services. So getting it back when you're engaging people about what is important for them, and whether that's, we know that patients who have access to green environments actually use less painkillers. These kind of implementation that can really impact patients at the ground level. So there's a breadth of topics that we're going to go through today. I can tell you that we're in a sphere of massive growth, that it's a really tricky, it's a new area. And I actually believe that, in some stage there'll be an Australasian College of Sustainable Healthcare and Climate Risk. I really think it's growing that much. I think there's huge amplification, acceleration. So what I would say to that, as we're just about to jump into the speakers soon, is that in terms of sustainable healthcare, it's been struggling. I think, the great work from CAHA and all the people have been doing for the last 20 years have been really fighting against the tide, but we're now in the era of 2024. We know that the climate risks, for anybody who's seen the recent publication around the State of the Climate report in 2024, we really are. That's the why we're here. We are up against the wire. It's really it'll be dark if we don't turn this around, and we can turn it around, but we need inspiration and leaders like your good selves. And the things that I would point to in terms of the demonstration of the growth is that in our hospital, it's now a real thing. In our ED, people know what sustainable care is. About financial sustainability. It's actually about patients and how we deliver it. In our hospital, we now have the executive are engaged, the data managers, the performance teams, and all up through infrastructure, and all of the sectors are coming good. And we need to do that through events like this, but also in your own hospitals and healthcare facilities around bringing people together online and in every meeting. So it definitely is growing, and it's all about money. And as I finish off this early introduction, although, healthcare is about giving, the best quality for the patients, but really we can win. Pop people on mute there. Thank you. So we can absolutely accelerate this by harnessing money. We're in our area, we're actually we've already on track to save well over $1 million and multiple millions when we scale some of the projects out. And we've used that money in advance for leveraging to get other people staffing, to get funding. And I think we'll come up in this in the Q&A at the end around how we leverage the organizations that we're already working together strategically, but also how we get funding to get people who are paid in the roles, in new roles, and also integrated, and how we get them out and scale up this great work that you're going to hear about today, and how we get this message out. And it's going to be getting money to get people funded and getting the comms out there and spreading in your own spheres and strategically coordinated. So with that, I would like to introduce our first speaker. This is Clinical Associate Professor Chris Leung. He's a clinician educator, a researcher, and an advocate. He wears many hats as part of the RACP, the GESA, at Austin Health, the University of Melbourne, and with DEA. He is passionate about climate action, as well as supporting our trainees so that we can all leave a legacy of health and hope and for generations to come. So I'd like to welcome Chris. He's going to speak on the Victorian Statewide Scaling Collaborative, promoting high-value care and low-carbon healthcare. Thank you, Chris.
Oh, thanks very much, Brian. And I too would like to acknowledge that I'm calling from Wurundjeri land. And as you said, high-value care is low-carbon healthcare. Indeed, 80% of the footprint of healthcare is from our clinical care. And unfortunately, 40% of that is unnecessary and even harmful. So Choosing Wisely is a national prescribing service initiative where we're the champion site to support evidence-based care, the right tests and the right management for the right patient. Very interdisciplinary process. And the governance was a Choosing Wisely working group as part of, and currently a sustainability steering committee, which again is very interdisciplinary. Our journey began when we got some seed funding to roll this out across 11 health services, both metro, as you can see here in Victoria, but also regional and rural. And what we found was we wanted to change the culture. So get our junior staff, students, clinicians to ask questions. Will this test change management? Are there any other tests? What are the goals of care? And why did you decide on this treatment compared to other options? Order societies had the top 5 recommendations. This is one from the Internal Medicine Society. And they are common things like how often do you order common tests like ESR and CRP and so forth. We also developed a Choosing Wisely toolkit, and this is freely available online for all health services to use. And what we did was we collected data across these 11 health services, and there were 28 low-value care practices across imaging, pathology, prescribing, across multiple departments, mainly in ED, ICU, and outpatients. And the great news is that in just over 4 months, there was a 33% decrease in low-value care practices. If there's ever a time for low-hanging fruit and rapid decarbonisation of a health service, then this is it. We have shown proof of concept that this can work across regional and metro health services. But only that, the staff were engaged. There was knowledge improvement. The staff said, this is our problem, this is our responsibility, this is our stewardship. And they 92 to 100% agree that this is what we need to do. And then knowledge of these questions also increased amongst our consumers, both in a multicultural sense and our first Australians. That was absolutely fantastic. There were lots of reasons for not for ordering unnecessary testing. There was concern about litigation and expectations, but we overcame this with things like education and also ensuring that they're just not doing things because that's just a routine. In terms of costs, the return on investment was fantastic. Like this only counts the cost of the test, but if you count the cost of chasing results, harmful care and so forth that was avoided, return on investment is about a year. So it's, and there was no reported adverse events because you were eliminating tests that were not actually necessary. And just some of the figures there in terms of the monetary components, I won't go through them in detail, but it all adds up. In Australia, we order 500 million tests a year in Australia. So as you can see, every little bit counts. Radiology, pathology. Some of our champions actually decreased chest x-rays by 72% in 6 months. So you can see huge benefits in a very short period of time. There was lots of lessons we learned about engaging our executives, making sure there's clinical awareness and project management. And also making sure that each department, each hospital is different and has their own priorities. So one key thing is that there is an algorithm that was developed which prioritizes that low-hanging fruit. Is a project something that's smart, that's doable, that's that there is expertise within the committee and the champions to do this, and is relevant to the hospital. So an MRI may not be relevant to our regional hospital, but may be relevant to a metro hospital. And these live dashboards were really useful. As a head of unit, for example, if there's a head of unit in gastroenterology, which is my specialty, you can see the coagulation profiles. And the important thing to note here are these little red dots. These are the repeat orders within 22 hours, which you often don't need. They've just, someone ordered emergency, the admitting intern ordered it in an admission, and then in the third order when they got to the wards. So completely unnecessary. And of course, it is our juniors and our interns who order it. So that's why education is so key within this. And the great news is now that we're incorporating this, you may have heard Sonia's talk a couple of days ago in this forum, incorporating this into quality improvement and meeting that triple bottom line, which is environmental, social, and financial. So we've at Austin developed this integration into our quality improvement processes, make this as business as usual, and using well-known quality improvement processes, which every hospital has to do under national standards. And then you measure success by using the quintuple aim: optimal outcomes, best patient experience, the best workforce experience, and a sustainable health service that provides equity to access to care for our patients. So please join us, choose wisely, and be part of the sustainable quality improvement revolution. It allows us to study the system and change workplace practices at each individual department and site. The dashboard I showed you is live and uses business innovation so that it allows heads of units and term supervisors, as per the new PMTV guidelines, to actually feed back to their juniors and say, in a very growth learning mindset, you've ordered 300 CRPs this week, the average is about 30. You might want to think about the indications for ordering a CRP. How is it going to change your management? And in fact, our juniors have really embraced this because they crave feedback. As they go for university, that's something that they really is embedded within their programs. And I've got here the AMC, the Australian Medical Council guidelines, which are percolating through pre-vocational training through the PMCV, but also vocational training through all the colleges, including RACP. And so our trainees will be more supervised and more fed back to than ever before. And that's a good thing, because we want to make sure that the experiential learning is fit for purpose. And so that really aligns to this framework. There's really an opportunity with this revolution that's happening in education to have choosing wisely, or as RACP calls it, evolve, to integrate within this framework. And not only that, because the planet's truly aligning, the sustainably quality improvement processes which occur in hospitals through national standards, and it's great work that Sonia's presented a couple of days ago, just really aligns well. This then also becomes an accreditation standard. So not only becomes an accreditation standard for education, also becomes an accreditation for your 8 national standards for quality health, so that together we can lead the change for care that's clinically sound and very environmentally profound. So if you want to choose wisely, evolve, and join us, there's a QR code there that you can click on, or there's my email there to if you've got any questions. Thank you very much.
Well, thank you very much, Chris, and you're ahead of time. So why don't we just use this? We're trying to keep people to, in around 10 minutes, but we will have plenty of time for questions and answers at the end. Chris, you and I haven't really worked together properly yet, and I'm to connect with you because there's a lot of parallels with what we're doing, and you've got great metrics there. So what I see is your passion. It comes across plain as day. I see that you've done stuff. You've already, you've made change, you've made impact, and you can see that in the data, and you've been engaging people. What would you say to people? I suppose my first question is, are you funded for your role, or how do you integrate that into your practice? It would be a question I think might come up, and I'll look at to see if there's anything else coming up.
Absolutely. That is a very hard lesson that we learned, and that's why I would like to share it. So choosing wisely, as you can see, makes really rapid gains. However, to be sustainable, excuse the pun, it does need that resourcing. It doesn't need a lot of resourcing. I'm talking about 0.1 EFT for clinical lead, and then a project manager, which is often a nursing staff, epidemiologist, which per health service. With that tiny amount of EFT, great things can happen. But what we found in many of the health services when we did this scaling collaborative pilot program, the issue is integrating into business as usual. And that's where I think SUS-QI, or sustainable QI, integrating into normal QI practices, I think that's going to be the game changer going forward. And if you heard Sonia's talk a couple of days ago, that's where it then becomes accreditation standards. That's where we hope that every health service then, by definition, resources it through this pathway. And that's what we hope too. So.
Yeah, fantastic. And I suspect, Chris, that you would have put in time outside of work and, an extra time as well, because the amount of work you've done, I'd say to get that at 0.1 FT would be, you need to be a magician. So well done. There's some wonderful comments coming through in the discussion. Really great presentation. There needs to be a clap icon. I like that. So there's, a lot of great feedback. So thank you so much.
It's a team effort, not just one person. It's multiple
100%.
people.
But this leadership, the leadership you show, do 0.2 in emergency, 0.2 is district, 0.2 state, and then we're looking at pathology. So you actually need to scale it up. I think even 0.1 is probably not enough.
Yeah,
we need other people
per health service. So 0.1 across each 11 health service. So 0.1 times 11. Yeah.
Perfect. Yeah, no, wonderful. Listen, this is great. Let's go on. We're going to come back to you, Chris, at the end. So thank you. You've garnered a lot of interest and enthusiasm on our chat. So thanks a million. That was a really fantastic, engaging presentation. I think there's a lot more under the surface. So we're looking forward to coming back to that.
Thanks, Brian.
Next up, we have our number 2 speaker is Kimberley Walters from Fiona, Stanley in Fremantle Hospital. And this speaking in an area close to my heart, which is sustainable pathology practices. So Kimberley began her career as a registered nurse, which I think is so important. We have, those clinicians who then get into the space in terms of other roles is really key. So Kimberley started as a nurse, developed a keen interest in the strategic and system-wide decisions shaping Western Australia health, and particularly in environmental sustainability. So this led her to pursue a Master of Commerce. And since then, she's gained extensive experience in healthcare in areas such as data, finance, safety, and quality. And Kimberley's just ticking off all the things. There's clinical, there's money, there's, and working around all the data and bringing it back home to patients in the safety and quality. So really looking Kimberley, and I suspect we'll be talking again offline around these shared interests around pathology stewardship. So over to you. Thank you very much.
Thank you very much. My name is Kim. I work at Fiona Stanley Hospital in Western Australia, and it was exciting to see Chris's presentation because there's a little bit of an overlap between some of the things he's working on and some of the things that we're sort of beginning to bring into our space. So obviously we're looking at environmental sustainability pathology practices, and our objectives starting out in this project were to have efficient ordering, to really integrate strong clinician-to-clinician education, and also to bring pricing models into that, because I think that often, I've worked in clinical projects before, I've worked in finance projects. I think something we're really missing is the finance team and the clinical team working together, because I think it can be a really powerful union. So the project team consists of myself and Ali, but we also have this huge committee. I'm really lucky at Fiona Stanley. We have a great environmental sustainability committee. We also have some fantastic data analysts, and we have some really engaged, interested clinical champions. And our 2 key areas where we get a lot of ordering are ED and AMU. So we've got a consultant and a registrar in each of those spaces who have dedicated time to work on this project, or are, at the very least, we are working on getting them dedicated time to work on this project. And obviously we all know about choosing wisely. So choosing wisely focuses on reducing unnecessary tests, treatments, and procedures. We want all of our tests, treatments, and procedures to be evidence-based, without duplication, free from harm, and truly necessary. And we know that about 30% of healthcare spending in Australia is unnecessary. About 10% of that healthcare spending is actively harmful, unfortunately. Now, there's a few studies, this certainly isn't every area, but there are a few studies that have demonstrated that there's a massive amount of wastage in pathology, and we know that there's waste here at Fiona Stanley in the pathology space. And one of the real issues with pathology wastage is that it's going to lead to a cascade of treatments, things such as if you perform a D-dimer, then there's protocols and there's procedures that need to be performed if that becomes positive. So we knew that this was an area we really wanted to work on and focus on. And we had a bit of a strategy. So we have focused on 3 key areas. So process, practice, and price in regards to carbon and dollar. So some of the process changes that we're making are things such as in the emergency department, our order forms have a lot of tick boxes. We have about 30 different tests listed. And so if you're a doctor who's a little bit junior and maybe a little bit unsure, then you're going to perhaps think, oh, we need all of these tests to be ordered. So all we're doing is just reducing the number of tests. So there's not that nudge to constantly be ordering more. We're also looking at some of the order lists, and long terms, we're going to be getting better electronic ordering systems because there's a space for those to be improved. We're obviously looking at improving our existing practice, and we're largely doing that through clinician to clinician education. So our clinical champions in each of our areas are giving really targeted, really specific education to people. Luckily, we have a dashboard that they can look at, see where their ordering is, where they want to be looking at reducing their over ordering. We've also got a campaign launch coming up, so we're hoping to really promote this across the hospital wide. But the area that I'd really like to focus on today, given the limited time, is price. So price in regards to carbon and dollar. Because one of the things that we found when we developed our dashboard and we were meeting with clinical staff and we were saying, okay, we can see that you're performing a lot of microscopy tests, a lot of calcium tests, what's going on here. Sometimes we were talking to clinical staff and they were coming back to us and saying, oh, this isn't quite right. We work in cardiology, for example, we're not really doing a lot of microscopy. So we found that there's this structural issue, and it's very, very common across the whole of Australia. And this is that in pathology, all of the pathology costs will be allocated on the whole to discharge specialty. This means if you have a patient, they're coming through ED, they get put into our acute medical unit or your equivalent, go to oncology, go to general medicine. All of those pathology costs are going to be allocated to general medicine. This makes running a pathology test really difficult because you don't have a lot of ownership and control. You can't approach people, demonstrate the data, say that it's in there, and then ask them to make a change because they don't have that ownership and control. So this is something that's really important for us going forward to change, and we're almost at the process where we can finally change it, because that's going to allow us to have long-term saving strategies with ongoing KPIs and reporting. So one of the things that happens in our hospital, I'm sure it happens in a lot of your hospitals, is that every month the executives will be meeting with the safety and quality staff, and they'll be meeting with the finance staff. And our goal in our hospital is that we'll be meeting with the safety and quality staff, the finance staff, and reporting on those metrics. But we also want them to be reporting on our environmental practice metrics, how much carbon has been reduced during this month. So how much carbon is reduced from pathology testing, or produced from pathology testing, excuse me. So we know that one full blood count releases roughly 116 grams of carbon into the atmosphere. And we know that 1,000 full blood counts is roughly the equivalent of 770 kilometres of driving. So it's an enormous amount of carbon if that's wasteful. There's a quick dashboard, but we won't do a live demonstration. Now, once we've gotten the correct allocation of our pathology carbon and price to the specific area, then we're going to develop really data-driven saving strategies. And the three areas that we're going to be looking at are repeat tests, tests performed right before discharge, and tests performed on palliative care patients that might not be necessary. This is because sometimes in data, it can be really difficult to get that human element. You have to sort of go that step further. You sort of can't look at a specific area and say, we're going to reduce that by 10%. We're going to reduce calcium by 10%. That doesn't make sense. But you can say, we're going to reduce our calciums that are performed within a 2-hour period by 10%, because it doesn't necessarily make clinical sense to be doing that most of the time. Now, overall, the changes that we'd like to see in Australia, obviously an influence on costing process. So pathology carbon and price should be allocated to the area that is ordering it so that they can have control over those changes. We'd also like to see technology be improved in the pathology space, whether that's improved in electronic ordering practices, or alternatively, whether that's just people being able to order pathology tests using the phone device that they're already holding, but with those built-in nudges that say, oh, this has been performed in the last 5 hours, are you sure you want to do it? Now, I've put in artificial intelligence in there. This is based on if they manage to improve the carbon cost of artificial intelligence, but it would be a fantastic thing if we can make that work for us. And obviously, we always want that environmental practice improvement. Thank you so much. That's my presentation.
Thank you so much, Kimberley. That was really fantastic. And I think the dashboards, the data, the visuals you have, and all the team that you've brought together, I mean, it's clear to me that this has been, a mammoth effort. How long has it taken you to get to where you are at the minute?
So far, the project's been going on since about mid-year, so we're rushing forward very quickly.
Yeah, you've done a lot of work in a short period of time. So we're looking forward to hearing, there's some questions coming up in the Q&A. So we're looking forward to hearing more about this in the Q&A at the end. Wonderful. Thank you, Kimberley. I'd like to now go on to our next speaker, and we're delighted to invite Jennifer Rutherford, who's joining us from the Hunter, New England Local Health District, just a few hours south of where we are right now in Gumbaynggirr country. Jenny is the virtual care manager for the HNE, so Hunter, New England LHD, with the clinic nursing, and this is so important, having this clinician experience engaging. And Jenny's passionate about the exciting opportunities that virtual care brings healthcare, which benefit our patients, like we talked about earlier, their families, and the services. And having this systems approach and developing a sustainable environment. So handing over now, and thank you very much for speaking, Jennifer, on reducing our footprint with virtual visits. Looking forward to hearing about it. Thank you.
Thank you, Brian, and thank you for inviting me to present here. It's really very exciting, and I'm very passionate around virtual care, and certainly the benefits that it provides not only our patients but also our environment. So Hunter, New England is a very large local health district. We cover 130,000 square kilometres, and we have one tertiary facility plus a mix of rural and regional facilities. We have a population of around 1 million and around 90,000 Aboriginal and Torres Strait Islander people who across 16 nations. And we also have around 18,000 health professionals who help and care for our patients every day. So virtual care can deliver high value care to patients by significantly improving access to specialist services, reducing costs to receive care, and allowing patients to receive care closer to home. Virtual care can minimise time away from work and school, and for rural and remote patients, this not only helps attendance to healthcare appointments but within their busy lives, but also saves on significant costs for travel, whilst also allowing other members of their care team, perhaps the GP, NDIS, or other allied health professionals, to be involved in treatment planning and building on high value models of care, improving patient outcomes. Virtual care also delivers benefits to clinicians, our services and our environment by reducing costs, increasing efficiency, and reducing carbon footprint. Clinicians can spend more time with their patients and less time travelling, and in many cases improving access to care for patients. Pressure on hospitals' car parking, outpatient waiting areas, and fleet car services can be reduced by virtual care when clinically appropriate, freeing up hospital facilities for patients and their families who really need them. So virtual care has been used to improve access to healthcare for patients in Hunter, New England for well over a decade. The critical care and retrieval teams have been part of the core virtual care services for Hunter, New England for many years. Using zoomable cameras, patients can be assessed and managed within their local health facility, and transfers arranged as needed. When weather incidents occur, which makes transfers via road or air unsafe, the options to manage patients remotely is largely facilitated by emergency clinicians keeping eyes on the patient to support rural staff deliver the care that's needed until transfer is possible. Hunter, New England has 97 critical care cameras or overbed cameras, which are not only available for managing the deteriorating patients, but also available to support accurate visual assessments when required. Hunter New England has 97 of these critical care cameras, which give great visibility and are used for managing deteriorating patients, but they're also available to support accurate visual assessments when required. The patient in the top right-hand corner was an Aboriginal lady who lived 6 hours away from our tertiary facility. She had a very severe dermatological condition, but was able to be diagnosed and treated and prescribed treatment without transfer. That not only kept the local treating team involved in her care and upskilled in the treatment that was suitable for her, but kept her close to her family during this difficult time. Next slide, thanks, Penny. Virtual care is enabling our Aboriginal patients remain on country with the support of family and community for clinically appropriate appointments. We know that this is important for Aboriginal patients to ensure that they receive the care that they need. Next slide, thanks, Penny. For patients receiving education, virtual care is a valued option to improve access for patients wherever they live, with less disruption to their daily lives and commitments. For patients post-stroke, virtual care is increasing opportunities for patients to access therapy regardless of where they live, which is contributing to secondary stroke prevention. For families receiving patient education, the option to attend these sessions virtually is allowing greater opportunities to attend due to flexibility to fit in with their everyday busy lives. Next slide, thanks, Penny. Many patients are not only receiving care from one clinician, but a variety of clinicians and health professionals who all contribute to their developing treatment plan and their ongoing health and well-being. Virtual care can allow these clinicians, including the GP, to be involved in specialist appointments, improving the multidisciplinary and coordinated care approach. Next slide. Virtual care can also be used to improve access to interpreting services. For example, with limited Auslan interpreters, using video connections is vitally important for the optimal delivery of care for deaf patients and their families. The tech is easy and simple to use, and it is now more readily available in wards, clinics, and specialist centres. Using USB technology and mobile devices, health professionals and patients are accepting of video connections and tools to improve these remote assessments. Slide 12. So how much do we in Hunter New England provide virtually? So currently we provide around 600 to 700 non-emitted video consultations per week. The ministry actually refers to virtual care as being phone as well. We know from patient reports that patients do prefer video, and that tends to be what we report on because anyone can use a phone. But during the last 12 months, this equates to just over 38,000 patients have received video appointments with their specialists. Next slide, thanks, Penny. Whilst many patients may choose to have their virtual appointments using tech, however, many have the opportunity to go to their local health service to have their appointment. They can be supported by admin staff who can connect them via PC to their appointment. We have 44 of these dedicated bookable rooms throughout Hunter New England. So in the past 12 months, patients and their families have been saved over 5.5 million kilometres of travel through virtual care. Next slide, thanks, Penny. This equates to 1,300 tonnes of carbon emissions saved by those virtual appointments. Next slide, thanks, Penny. This has also saved the patients nearly 9,000 nights away from home. Next slide, thanks, Penny. So this is just explaining a new brochure that we've just designed, advertising those telehealth rooms where patients can go, greeted by administration staff, and have their appointment when we know that rural connectivity can sometimes be unreliable, or patients actually choose to go to their health facility to alleviate the stress of connecting and ensuring that they are able to concentrate on their appointment with their specialist. These are located throughout our district. Next slide, thanks, Penny. Virtual care is now one of the dedicated strategies to which LHDs are required to align to work towards improving patient care and outcomes. This also links with our district infrastructure and sustainability team as one of the adopted strategies to reduce carbon footprint from the district's fleet of vehicles, encouraging the reduction of unnecessary travel, saving clinician time and improving access for our rural and remote patients as a focus. Next slide, thanks Penny. We also know that health budgets are limited, and savings to travel and increased efficiencies of our staff will help us meet our ministry performance targets, as well as operating within our limited financial resources. Health professionals wanting to offer virtual care are now supported by principles and guidelines to ensure safe delivery of care virtually. Research is emerging that supports virtual care as an option for high value, low carbon healthcare. Next slide, thanks Penny. However, there is still a lot to do, much more to do. So how are we engaging those health professionals and clinicians not yet on board? These are some of the questions we ask. We ask them to ask of themselves. Could virtual care save my patient unnecessary travel? Could virtual care improve the coordinated care for my patients? Could virtual care reduce my travel time? And could virtual care allow me more time to spend with my patients? Next slide, thanks, Penny. Most importantly, our patients love virtual care. The Bureau of Health Information results confirm that patients see virtual care as a suitable option, whilst they prefer video over phone for specialist connections. Over 90% reported good or very good experience with their virtual appointments. Next slide, thanks Penny. The next steps for virtual care within our district are defining more opportunities where virtual care can support patients receive acute care out of hospital. Offering patients the option to receive acute care in their home when safe to do so will be an important change in the healthcare service delivery, providing many benefits to patients, services, and restricted healthcare budgets. Our united goal is to ensure patients receive the right care at the right time and in their place of choice, wherever most appropriate for their needs. Thank you.
Fantastic, Jenny, and well done on dealing with the technology. So I think some people I can see people clapping in the background. Yeah, it's you did great. I think, listen, I've been a GP working in emergency. I also worked as an acting director of the hospital and the home team before they set up with COVID. I see the absolute value, again, from patient-centered approach. If you had one, and just to say, the Hunter New England is a very busy LHD. I've been down to the John Hunter. You know, it's amazing to get the people who do not need to be in a building to be at home is really important for everybody. If you had one learning point to provide to people, what would that one learning point to be who are trying to scale up and maybe struggling against some headwinds to develop their virtual care?
I think the key point is to get, virtual care is appropriate in every service, and there are people who are challenged by it, but I think it's encouraging every service to consider when it's appropriate for their patients. It's no one's role to tell clinicians what care is appropriate for them, but it's about keeping the patient at the centre and thinking about them, and the other benefits to us in the environment come, but keeping the patient at the centre of what we're doing and ensuring that we're doing the right thing by them when we ask them to travel. And for some of our patients travelling 6 hours for an appointment that takes 15 minutes is not the best care for them, and it's not doing the right thing for them. So it's really ensuring that every patient, every time, which is our the motto that we work by, but just reminding clinicians of that, and working slowly, I guess, with that, because the technology is there. It's about change and getting
Beautiful.
people to
So what I hear you saying is really getting the word out there, putting it in people, in front and center, that the communications, and making it an accessible option. Thank you so much, Jenny, and we'll be hearing more from you later.
Thank you.
So we are running a few minutes behind schedule, but that's okay. We've got a bit of wiggle room with our Q&A at the end. I'll ask the remaining speakers if we can try and keep to 10 minutes, but it's been wonderful so far. So I'm looking forward to welcoming Dr. Alex Surgery in Hastings. Dr. Alex is an ophthalmologist at the eye surgery, which is solar powered, off grid, and it's an ophthalmological surgical centre in Hawke's Bay, in a beautiful part of New Zealand where I've been. So it's also carbon neutral, and all the staff are involved in the development of these environmental practices. So well done. It sounds like a shining light role model. And Alex is going to talk around our answer to a tough question. How does green healthcare link to quality health? Forward to hearing from you now, Alex. Over to you. Thank you very much.
Thank you very much. Hopefully everybody can hear me and see the slides. It's wonderful to be here, and the quality today is amazing. So yes, the talk here, why is this a tough question? I think there's 5 problems to overcome. Our experience achieving quality through sustainability, and then strategies to overcome those barriers. So this is our place. We've got solar power. This is our solar production. This is yesterday. So the yellow area is what the electricity we produced, and the purple is what we used. If you say to somebody, after you've done an operation, your operation was solar powered, they're universally delighted. If you say to somebody before they have an operation, your operation's going to be solar powered, they're universally worried. So what's going on there? This is the problem number 1, and this is the big one. It's dilemmas. So there are 2 types of dilemmas according to psychology. There's the right versus wrong dilemma, sustainable versus non-sustainable, the easy win. But what's going on with the patient who is about to have an operation? They're immediately thinking, well, what if the sun goes behind a cloud during my operation? So this is the right versus right dilemma, sustainable versus quality. And in healthcare, I don't think the screen's big enough, but this is sort of the balance of power. Quality is always going to be seen as more important than sustainability in healthcare. Also, problem number 2, eco products is seen as worse quality, and the reason for that is because they have been. A lot of them have been much worse quality, and that has been well documented. The next problem is there's a mismatch between quality and sustainability. This is the World Health Organization definition of quality. There are 7 areas, and sustainability is a part of one of these areas. So there's not an obvious link between the 2 when you're talking about them. Number 4 is balance. These are the 7 areas of quality, balanced precariously to balance the workload. This is why you need people who are involved in the healthcare situations to be able to be introduce changes. It's not an easy situation to introduce change into. And then number 5, you need to change behavior. Healthcare has been running enthusiastically in the wrong direction for several decades with the use of plastics. And this has got to be a different mindset for people. So these are the 5 psychological barriers. Quality is a higher priority. Eco products have a bad reputation. Sustainability is only a small part of one of the 7 elements of quality. You've got to maintain balance, and you've got to get people to change their behaviors. So this is what we did. So this is our pathway. We wanted to use reusable cannulas. We use about 4 or 5 of these during cataract surgery. So if we wanted reusable cannulas, why not reuse the other stuff that we can change to reusable as well? So we needed to increase our CSSD capacity to sterilize more and more things. So we needed an extra autoclave, which needed staff education and extra plumbing in the building. That gave us distilled water, which was very nice. We were buying that in bottles before. We also needed to upgrade the building to take the extra weight of things and have extra cooling racks. And air to sterilize instruments. You clean them and then you blow them dry with medical air, and then you can sterilize them. We were spending $1,000 a week on bottled air just to dry all these things before we put them in the sterilizer. So we got an air compressor, and also we needed lots of cooling. A second autoclave using steam in a small room made it a very hot room. Fortunately, we got the solar power to power the air compressor and the cooling. And the people we're working with for the autoclaves, we got an international prize for that, which is always very good for the people involved. We also had HR issues with this. We needed extra time to do this, and people's hands were getting tired. Flushing through small cannulas several times for every case is arduous work. So we worked with a local engineering firm to develop a new machine which would automatically flush these through for us. After several months of trial and error, that still wasn't working very well. So we pivoted to a washer disinfector machine with special trays and attachments in there. And we've now got better cannulas, and with all the reduced need for instruments, we've got new cataract packs, which are a lot cheaper with a lot fewer things in them. So this is anything but a straightforward, easy pathway. But if you look, now we're at the end of it, looking backwards, this is a heat map of what we're spending money on compared to what we were doing before. And this is what we're spending time with compared to what we're doing before. And this is the quality of the care that we're able to produce compared to what we were doing before. So what we've got in here in terms of the quality is we've got infrastructure, we've got resilience, we're away from supply chains, we've got a much stronger platform to build things on. To take the air as an example, it's changed from being an expensive commodity to use as much as you like situation. So this is a similar way of saying the same thing. These are the 7 elements of the quality definition, and the perception of sustainability is this one small part of one of those things. But this is what we actually found when we've done our pathway, and so it's very, very different. So this is a sort of a graphic to give you a big picture of it. This is a caterpillar with resources coming in and waste coming out. It represents a linear economy. And so you want to evolve from a caterpillar into a butterfly. And so with all of these different things, infrastructure, reusable things, renewable energy, reduced areas, better CSSD, what you're doing is still putting resources into the system, but you're retaining them and building up. And with every cycle, the whole system gets stronger and stronger and stronger. And so it's much more resilient and much more able to look after itself, and less waste is coming out the other end. And more of your investment of resources is being retained to make the system stronger and stronger. So this graphic represents a patient pathway through any healthcare system. There's lots of interactions: first interaction, center interaction, third interaction, fourth interaction. So this is how to change behaviors. The point is that there's always change going on in healthcare. Each one of those interactions is going to be complex with technology and people and all sorts of things involved. All of these things can go wrong at any time. You've got supply chains, breakages, staff changes, new things becoming available, and so on. And so what you have to do is to be a voice in these changes. It's going on anyway, piggyback onto that and think changing from the caterpillar to the butterfly when you're doing it. But when you put forwards a sustainable option, don't put it forwards as a sustainable option. Talk about it as a quality option. And I suggest that you use that World Health Organization definition of quality. So it will be safer because of these reasons. It will be more effective because of these reasons. It will be more people-centered because of these reasons. It will be more efficient because of these reasons. If you do it that way, it gives you 2 things. The first thing is it changes you from imposing what you want, the sustainability, onto what most healthcare professionals perceive as what they want, which is the quality side of things. So you become an enabler rather than a dictator. The second thing is that if somebody wants to bring a counter proposal forwards, they're going to have to match you on the quality issue rather than them having the more powerful quality argument and you having the less powerful sustainable argument. If it's evens between 2 different options, you can then point out that yours is the sustainable option, and that'll add weight in a positive way. So that's pretty much all that we wanted to say. There are 3 big strategies: think towards butterflies, be a voice in change, and talk about quality, not sustainability. Thank you very much. Hopefully some of this can be helpful for you.
Wow, Alex, that was impressive. You're more than just an eye surgeon, I think.
I have a very good team around me. Very good.
Yeah, but on other work, we obviously haven't met before, but I'd be keen to catch up again. Have you done other qualifications, or are you just a bit of a genius? Because what you've come up with is there's a lot of complexity and nuance and learnings from psychology and change management, et cetera, et cetera.
Yeah, no, it's kind of this is something this pathway has been 4 or 5 years in the making. And for 2 years, I've been telling people, and we're solar powered, and looking at them going, what's that got to do with how good my cataract surgery is going to be? So that it really is that, I mean, the difference between quality and sustainability in the receiver's end and also in other practitioners' psyches is huge. And if we don't sort of acknowledge that and deal with it, then it's going to be a real stopping for progress. So, you know, we're very, very lucky. Our superpower is being small. We can make changes, implement changes, fail, try again, fail, try again, and you know, move forwards because we're a small team and we're making our own choices. That's really how
I think it's fair to say that, yeah, I think it's fair to say that you're not, your centre is an absolute role model, and I'm not surprised you got an award. And I think there's a lot of learnings that we can unpack. I'll certainly be watching that session again with some of my team, and we'll be looking through it, because I think there's some really valuable areas. I love the way you did the mapping and the heat maps and the puzzle. So we're certainly going to come back to a lot of what we talked about there. Fantastic. Thank you, Alex. We will look forward to the Q&A session with you. And I'd encourage people to pop up on the discussion forum, the Q&A for Alex and the rest of the team. Thank you, Alex. We're going to move on to our next speaker. We have now, Kaz is going to have to help me with his surname, because I don't want to say it wrong. So we'll get Kaz to say it properly. Dr. Kaz works in Barwon Health, and he's a specialist anaesthetist, and he's the chair of Victoria DEA Sustainability, which is fantastic. And he's going to be speaking on managing nitrous oxide leak in healthcare facilities. Kaz and I actually were emailing through a separate group around this very subject this week. So it's exciting to hear from you, and looking forward to your talk and what we talk about after, and building, because really what's happening I see today is there are a lot of sparks flying around different parts of Australia, and we're bringing these sparks together to make a bit of a wildfire of change across our different systems. Thank you.
Fantastic. Thanks, Brian. My last name is pronounced Woinarski. Yeah, I'm really passionate about this topic, and I'm really humbled to be a part of the presenters today. There've been some really high quality discussion and PowerPoint slides. I echo that heat map was wonderful, and I'd love to create something similar for my project. So I'll get into it. But I'm Kaz Woinarski. I'm an anaesthetist at Barwon Health on Woiwurrung country. Today I'm providing some insights into addressing nitrous oxide infrastructure leak and how to get it going in your place of practice. This topic represents high value, low carbon care, in that the current leaky system represents the very opposite. Nitrous oxide that enters the atmosphere without impacting patient care is a clear example of high carbon and low or even zero value care. Importantly, solutions to this problem are now known and have no adverse effects on patient outcomes, and nitrous oxide is still an available therapy for clinicians. I don't have time to go into the full acknowledgements, because I could probably do 10 minutes all up. But basically, in essence, this is another another fantastic healthcare team sport, and you will need to put a high functioning team together in order to achieve results like those achieved at St. Vincent's in Portland, Oregon. I need to give a special thank you to my wife for doing more than her share of bedtime so that I can facilitate and attend online meetings. So what is the problem with nitrous oxide? Well, nitrous oxide is a potent greenhouse gas, and it continues to exert harmful environmental effects for some 100 years. It is a powerful oxidizer and damages rubber O-rings required to create tight seals. It is a medical gas supplied to most hospitals via a reticulated infrastructure system or a medical gas pipeline system. This pipeline is pressurized by a manifold, which is a collection of large gas bottles. The accessible outlets to administer that gas are found all throughout the hospital, in birthing rooms, operating theatres, anaesthetic bays, emergency departments, and paediatric procedure rooms. There are also reports of disused outlets being found in non-functional areas of the hospital, such as libraries. Historically, nitrous oxide was used in much greater quantities than it is used today. As nitrous oxide is a gas, it is challenging to measure how much each clinical area requires. Historically, there has been little communication between facilities management and clinicians on this issue until the last 5 years. And as a consequence, hospitals generally purchase much more nitrous oxide than is necessary for clinical demand. 2 or 3 years ago, when we started this process, there were case reports of leak, but the size of the problem was still being determined. Answers to solving the problem were in their infancy. Now we have high quality evidence and support of how we should manage this issue. This ranges from reducing emissions from nitrous oxide being a target with the Australian Health and Climate Strategy to nitty-gritty toolkits like the one developed by Providence Healthcare in the United States. These are but a few. A personal one that I've been working on is the Doctors for the Environment position statement that we're in the final steps of publishing. As with any issue, there is red tape to find a way around. A group of clinicians have advocated to allow solutions to be implemented more easily. The proposed advice is hopefully going to be ratified soon. This means that hospitals can basically do what they want with regards to their nitrous oxide infrastructure system, mostly allowing for some flexibility to transition to point of care cylinders. We should remember that these are guidelines only and that there are hospitals already functioning without piped nitrous oxide. That's not to say that these hospitals don't have any nitrous oxide, they're just supplying it through point of care cylinders. So how to make this change and make impact in your place of practice? Some of you will know that anaesthetists can only get to C in the alphabet, so it'll be no surprise that this is a 3-stage plan. This plan will take somewhere from months to years to implement. This plan was developed by Providence Healthcare. These phases can be run simultaneously, and there is an assessment phase, an establishing portable supply phase, and there is a decommissioning the central supply phase. So the assessment phase is about answering the questions: how much nitrous oxide do you need? Where do you need it, based off the craft groups that practice in your hospital? And comparing this to how much nitrous oxide you buy. Many of you will find that your hospitals have been purchasing some 50 to 95% more nitrous oxide than is clinically administered. The data on the screen is from the place where I work at Barwon Health, noting that whilst clinical requirements represented in the blue, orange and green lines are relatively constant, purchasing volumes fluctuate by some hundreds of kilograms, and they have consistently been 45 to 55 greater than clinical need. The next phase requires the establishment of a portable supply system to meet the clinical demand for nitrous oxide. This requires immense teamwork and is much more about the processes to ensure patient safety. This will ensure storage and security, as well as education of staff who administer nitrous oxide. This is mostly to manage the unique properties of nitrous oxide, in that in a room temperature bottle, the majority of the bottle is a liquid form with a gas on top of it. And determining when all of the liquid in the cylinder has transitioned to the gas phase and you're starting to depressurize your cylinder is a topic of great debate amongst some friends of mine. The final stage in this project is to depressurize and deactivate the piped infrastructure. 4 hospitals in Australia have currently made this step. This step is important as there are hospitals that have disconnected their nitrous oxide delivery systems, generally anaesthetic machines, but due to leaks in the system, significant volumes of nitrous oxide are still emitted into the atmosphere. This is a clear example of high carbon, zero value healthcare. So hopefully this has given you some practical advice on how to undertake an impactful project at your healthcare service. Please get in touch via this QR code if you would like to collaborate or follow up. And please keep your eyes peeled for the DEA position statement on this issue soon. And hopefully, with enough persistence, we can see statements on this issue from the relevant colleges. Thank you.
Kaz, that is a superb and concise summary of really quite a complex topic in a nice and simplified version. So well done. Again, I'm going to ask you maybe a similar question I asked Jenny. If there's one tip that you could give to people, for example, there's a registrar in our hospital who's taken this on only last week and he's starting out. What was the one tip that you might give to people out there who want to start something like this? And how they gain success from the things you've learned?
I think the key is collaborating with colleagues who are further down the line than you. I've been working at this pretty tirelessly for about 2 years, and what we know now is streaks ahead of what we knew then. I think, as with anything, the first step is just looking at your numbers, and trying not to fall over when those numbers kind of finally dawn on you. Because there are a few kind of light bulb moments that we've had.
Brilliant. So here, get your team, persevere, and learn from other people's their journeys, and get on with it and get the but it's really, you can see the momentum is just building with trailblazers like yourself and Alex and all the people already doing a lot of the hard work. It's going to be a lot easier for people to jump on and do these systems in their own hospital. So thank you, Kaz, and looking forward to the Q&A with you after. So I'm delighted to introduce our final speaker of the day. We've got Dr. Mike Forrester from Deakin University. So Mike is a general pediatrician in University Hospital, also a senior research fellow with Deakin University in the Faculty of Health and the Institute for Healthcare Transformation. And that's what it's all about today in this forum. So he's going to focus on the co-benefit of opportunities of this transitioning to an environmentally sustainable healthcare, and how can we deliver this high-value healthcare today in a way that cares for the planet and the future generations. So Mike is also the Victorian Chair of the Doctors for the Environment Australia, and he's also a member of the National Sustainable Healthcare Group on DA, which I would actually, if anybody who's not a member, I would definitely join that. They had a fantastic meeting on Monday that I was able to link in with them around. So we're looking forward to Mike's presenting today on sustainable asthma care, a roadmap and a roundtable report. So welcome, Mike, and good to see you. We met in person, I think, back in Brisbane at the DA conference a few years ago. So it's great to connect with you again. Looking forward to hearing your presentation.
Great. Yeah, thank you, Brian, for the introduction. Thank you to CAHA and the GGHH team for the kind invitation to present and be amongst this stellar lineup, and thank you all for the interest. So yes, I'm a Barwon Health paediatrician, also based on Motherwong country, where I have been working with Kaz, and I have an academic and advocacy interest in environmentally sustainable and high-value healthcare, and we're starting to frame these win-win opportunities in terms of co-benefits. We've recently launched the National Sustainable Asthma Care Roadmap Roundtable report with the Federal Assistant Health Minister, Jed Kearney, and there's a scan code linked here if you haven't seen it yet. And I think this is a great example of a Scope 3 decarbonisation co-benefit opportunity, which I hope will be clear to you in about 10 minutes' time, and I'll be interested in your thoughts and questions. The initiative was consumer-led by our project partner, Asthma Australia, representing people with asthma in Australia. We worked with 50 organisations that you'll see listed here in a series of system-oriented roundtables to think together about how do we improve asthma care, which hasn't really changed in 20 years in Australia, while decreasing the greenhouse impact of the 20 million high global warming potential hydrofluorocarbon inhalers that we're using in Australia each year. And thank you, Alex. I will keep trying to frame this all as a quality improvement project. So the impetus for this project was the release of the Australian National Health and Climate Strategy, which highlights opportunities to decarbonise the health sector. As you know, Scope 3, which is about 70% of the health footprint in Australia, is really all of the resources required to provide care, including pharmaceuticals in the supply chain. And of the pharmaceutical footprint, hydrofluorocarbon propellant inhalers are the standout priority here, highlighted as Action 4.14 in the National Strategy. In the NHS in the UK, they estimate that respiratory inhalers account for 13% of the NHS's carbon footprint related to the delivery of care and 3% of the total health sector emissions. And to put that in perspective, their modelling suggests that transitioning to low greenhouse gas asthma care would have a greater decarbonisation impact than transitioning to renewable electricity supply for the whole NHS. Many of you will know that the hydrofluorocarbon propellant from 1-salbutamol inhaler has the same climate impact as driving the average vehicle 285 kilometres. This is because hydrofluorocarbons are 1,300 to 3,300 times more potent greenhouse gases than a CO2 molecule in the atmosphere, and there are over 800 million of these devices sold around the globe each year. For those who will continue to require a propellant metered dose inhaler, and we'll talk a bit more about that, there are, and that sort of particularly includes the use in acute care, young children, less than preschoolers, that is, and those with frailty. There are some new hydrofluorocarbons in development with a lower greenhouse impact, but the timing of that introduction and the cost to consumers is not known. Fortunately, for most people, the same amount of medicine can be delivered by a dry powder inhaler with about 3% of the greenhouse footprint. So another fun fact, did you know that shifting one person with asthma from a monthly PMDI to a dry powder inhaler, seen in the bottom bar, would have a slightly bigger carbon footprint reduction impact than that person becoming a vegetarian, which you see in the second bar from the bottom, and bigger again than avoiding a 3-hour flight per year, which you see in the third bar from the bottom. So let's look at the relationship between asthma treatment as it stands in Australia and the associated footprint, and I'll indulge my biases as a paediatrician here to focus on some indicative data regarding young people. So firstly, short-acting beta agonists or SABA relievers, predominantly salbutamol, which is only available via a puffer, a propellant metered dose inhaler in Australia, are overused and over-relied upon. We're using about 15 million per year in Australia. Probably more than half of these are purchased over the counter, so it's difficult to really estimate, and we aren't actively collecting this data in the national asthma indicators. Dispensing 3 or more SABA canisters in a year is an indicator of poor symptom control and is associated with a doubling of emergency department presentations in both adults and children, with numbers rising with each SABA dispensed from there. By the time you're on 1 a month, 12 a year, that is, you have a more than 30 times odds ratio of dying from asthma. So this is really critically important to think about how do we reduce this SABA over-reliance. Inhaled corticosteroid preventers are one of the most important answers to the question of how we improve things. They're very effective. There's good evidence for that, but they are significantly underused, with adherence to ICS in young people being at about 28% in a systematic review. About 60% of asthma hospitalizations could be attributable to poor adherence across the population. Unfortunately, despite us all trying pretty hard, asthma care in Australia isn't going so well, as you can see from this large national survey of young people with asthma. Uncontrolled asthma is clearly a burden for the individual, but it's also really expensive, with a burden of disease estimated to cost Australians $28 billion in 2015. And the greenhouse impact of approximately 25 million inhalers sold in Australia each year, of which around 80% are high global warming PMDIs, can be estimated at over 600,000 tonnes of CO2. That's similar to the annual emissions of about 350,000 vehicles. And if we think about it in terms of how many trees would it take to absorb a similar amount, the amount of CO2 that would cause the same greenhouse impact, we're talking about 60 million eucalyptus trees per year to absorb that equivalent greenhouse gas. Well, there's potential for compounding effects of high carbon healthcare. This climate change and its causes, predominantly fossil fuel extraction and combustion, increase asthma incidence and exacerbations via air pollution, increasing allergens and combination impact. So you get a bit of a vicious cycle there. And Wilkinson and colleagues really tried to help break down, well, where is this footprint coming from? And just they really bring home the 2 really important points in this slide. This study, the data was derived from 500,000 primary care asthma patients with linked hospital episode data to assess the footprint of all aspects of their care: inhalers, primary care visits, other medications, emergency stays and admissions, including ICU. And the first point is that the carbon footprint of asthma care is about 3 times greater when asthma is not well controlled, which you see in the middle column, confirming that high value asthma care is low carbon care. This is a great example of a co-benefit opportunity. Secondly, the large majority of the asthma management carbon footprint comes from the inhalers, from the propellant. The SABAs in blue, the preventers in green, and you'll see in the gold, the healthcare resource utilisation is actually a really small contributor, as are the other medicines like oral steroids, etc. So how is this all linked to the opportunity to improve asthma care? Well, there's a quantum shift occurring in community-based asthma treatment. In fact, as required, short-acting beta agonists like Ventolin are out. They no longer have a place in community treatment guidelines based on the international best evidence. So this chart from Gina suggests that for everyone aged over 12 with asthma, in the recommended treatment track 1, it's now all about anti-inflammatory reliever therapy using combination inhaled corticosteroids and a long-acting version of a beta agonist, which is formoterol. So it's like a longer-acting form of salbutamol. And the idea is that every time you have some reliever, you then get your inhaled corticosteroid preventer with it. So that gets rid of that problem of adherence. And that's at the first 2 steps. And then if you need a daily preventer, you go on to steps 3 and 4, which where you use the same device as your daily preventer and you use it as your reliever. So one device for everything makes it easier and safer. So the UK guidelines are about to follow suit. In paediatrics, the RCH and Australian Paediatric Improvement Collaborative guidelines have followed suit, and they'll say, and this is so they say the same for 12 plus, and we're awaiting the outcomes of about 5 trials underway for primary school age kids, but it will very likely follow suit. The National Asthma Council guidelines in Australia, national guidelines, are currently under review, due out in early 25, and we may see something very similar there. So the changing guidelines away from salbutamol to air only, or air with maintenance, which is generally called MART, maintenance and reliever therapy, offers a significant co-benefit opportunity. In Australia, ICS formoterol is readily available in a range of dry powder inhalers, which have 3% of the greenhouse footprint of propellant inhalers. The 3 dry powder options you can see are marked there in this snippet from the NAC device chart. And these are the ones that contain inhaled corticosteroid with formoterol. This is a really important point, though. The greenest inhaler remains the one that the person can use correctly, whether that's a propellant inhaler or a dry powder inhaler. The one that will reduce their risk of SABA overuse and of severe exacerbations. The good news detailed in the report is that people, including kids, like dry powder inhalers and can use them as well or better than propellant metered dose inhalers in the community setting with training, as long as they can take a big breath in less than 3 seconds. That's the best sort of surrogate marker of inhalational flow. And the potential advantage, well, particularly young people will tell me that what they like is having just one device to remember. They can keep it in their pocket and they don't need to have a spacer with them, because dry powder inhalers don't need spacers and the other ones do every time. So again, a big co-benefit opportunity, and we could potentially improve people's care and reduce the footprint of their care by 97% by making this change. This is a system map that you'll see in the report that I won't spend time on, but this is what the participants use to generate their collaborative recommendations. This really demonstrates the interconnecting factors driving the quality and the footprint of asthma care. And I'll skip through to the recommendations arising now. So the recommended goals from the round table, you'll be able to skim through if you look at the executive summary in the report, and then you can jump to any details in the body of the report. Goal 1, you can't change what you don't measure. So establish a data dashboard to display the national indicators of high quality and decarbonised asthma care. Goal 2, we need consistent recommendations to make sure that guidelines are concordant and all of the secondary resources are concordant with those consistent guidelines, and we need a mechanism to really achieve that. Goal 3, we need clinician education coupled with digital enablement, really to make it much easier for prescribers to provide guideline concordant care and to provide the people they're looking after with updated resources. Goal 4 is to launch a research-informed multimodal national public awareness campaign targeting people with asthma and helping them understand the options to reduce the footprint of their care if that's appropriate for their needs. Goal 5, to help with this, we need to make access to guideline concordant medicines equitable and affordable for all. And we need to reconsider how to provide emergency access to over-the-counter medication while helping people transition to a safer model of care. Goal 6, we really need to support research to implement and evaluate this transition. Goal 7 was related to device collection. So the vast majority of used devices still have quite a lot of propellant left in them. They go in the household waste at the moment and out into landfill where the hydrofluorocarbon inevitably leaks out. They need to be returned and destroyed at high temperature if we want to mitigate this problem. And goal 8 is a big picture look at health in all policies, which is mentioned in the national strategy And we really need to work with the right stakeholders to think about how to improve air quality and reduce the incidence of asthma in the first place. So key stakeholders have now established a steering committee to progress the roadmap. Please reach out if your organisation would like to contribute to this process. Simon Judkins, I can see you're online there, and we need to talk to you about ASIM input to progress this work. But please contact me if you'd like to be involved. I'd like to acknowledge the many leaders who've contributed to this roadmap, and I'll just close with this slide. Transitioning, which again has the link to the report. Transitioning to a high quality, sustainable model of care is something we can all be part of in our practice, hospital, or other areas of influence. Let's promote co-benefit opportunities for our patients and our planet. Check out the GINA 24 report, particularly the air regimen with or without maintenance, which is an easier and better option than using separate inhalers. And a dry powder inhaler will be relevant to most people from school age up, so consider that option. Thanks again to CAHA and the GGHH team for the kind invitation, and thank you for your interest.
Wow. Thank you, Mike. That was a whirlwind of all of the presentations of, the depth of knowledge and data, the successes, the passion and the investment of your own time. So, and Mike, that was really superb. I actually looked at this topic before I picked up the pathology. I put it in the too hard basket. So well done for you taking out of the too hard basket and really running with it. And we will be looking to, within New South Wales Health and all of our SEMCAN with our emergency college new network, we'll certainly be looking forward to working with you to propagate your great work and all the other people. Thank you. I'm going to just acknowledge online. So we have a really large number. If you click on the bottom attendees and sponsors, you see quite a lot of people are online, with people dialing in from Broome Hospital, Cunnamulla Hospital, Monash Health, Climate Catch Lab, and we've got a whole people from all parts of Australia. I'd like to have a special shout. I see our founder, Fiona Armstrong, is also online. And Fiona, you must be so proud seeing what all the work and effort you've put in down through the years, and it's still proud to have you online and look. Have to meet up with you in person. Actually, when I joined the board, you'd moved on to other adventures and really look at. So thank you, Fiona, and all of the other team for joining us. So great slides, great talks, great impact. We talk about signal versus noise. I think there was a lot of signal and there wasn't much noise there from all of our speakers. So we had Chris speaking at the beginning about choosing wisely in Victoria. We had Kim speaking from We had Jenny speaking and done a great work with the slide issues, talking about virtual care. Thank you, Jenny. We had Alex speaking about eye surgery and systems thinker. And I'm so impressed with all of these presentations and, seeing the role modeling that we've been demonstrating today. We had Kaz speaking around nitrous, and obviously just Mike on the asthma plan. So what a wealth of knowledge. And I think the recording from these sessions should be shared, after 4 months. We'll talk with the CAHA team, but I think they'll be accessible, I understand, maybe after 4 months. And I think we should get this message out there. All the great work that CAHA, GGH and Green and Healthcare Forum pulling these stars together. And thank you for everybody putting their own time into it. So I might also mention the possibility of sharing slides. So we'll just ask if individuals are happy to share the slides. If people want the slides, maybe to link in with our CAHA team. I'd also encourage people to look at the discussion forum. There's a lot of great questions. Mike, you've got a question there that you might answer about the 600 tons or kilotons. So we'll leave that up to you. And we'll go to the Q&A in a moment. So I'll just bring that over. So now thank you for all those wonderful sessions. Before we get started, we are in the Q&A. We're going to go into a Mentimeter link in the chat. That's a Mentimeter link and a QR code on the screen. So we'd love everyone to have a think about your key takeaway you'd like to share from this session, and you'll be able to see everyone's responses in that Mentimeter. There's also a message around the posters and videos on this topic, which will be available in the poster room. I thought that might be a bit tricky to look into, but actually when you look into it, it's not too hard at all. It's in the lobby. So look at the poster room in the lobby, and it'd be worth your while spending on that. So as we go into the Q&A, I saw, and that's brief. nation. So we've got all these sites from around the country and beyond, and how we work together in the strategic coordination. So we've got Australia and the states and territories. We've got the organisations, which I'm not going to list, and then we've got the hospitals. And working with our executives and the clinicians and the middle grade managers, that's how we're going to bring the strategic coordination. First theme. Second theme is sharing resources, and we really need to look at where the platforms are. We can do this nationally, that we're not just sharing amongst our own state or our own discipline. So how we share. Number three, we talked at the very beginning, funded roles is absolutely key. It has to be sustainable. Otherwise we get burnout and people are working too much in their own time. The fourth theme that I saw today was data, the importance that we have to measure before we can change. So we really need to drill down on that. Last theme I saw more are comms, the communications, and getting these great work out to the rest of the healthcare audience and the wider spectrum. So I'm going to go to Q&A, and I don't, Glenn, you're in the background if you want to speakers in, if that's possible. I see them in the preview, and perhaps we might do, we've got about 15 minutes. I need to do something at 1:40, but I will jump back in for some networking, and it's great to see all the speakers. So what we might do is we might go just through the timeline so everybody gets a fair chance, and we'll maybe bring things out for Chris's talk at the beginning. So Chris, it was a wonderful overview of the Choosing Wisely, and it goes back to that strategic coordination. We've got Simon Judkins, who was mentioned earlier, in Victoria, who works with us in the chair of SEMCAN and AMA and multiple other ones. So how do you see the strategic coordination with Choosing Wisely? And we know that works with the Australian Commission on Safety and Quality in Health, and Carolyn Hull, as the Chief Medical Officer, has been doing some great work on that. But what do you see with Choosing Wisely or some other similarly named organisation to bring us all together?
Yeah, no, great question, and that is something, and I absolutely acknowledge Simon Judkins' absolute fantastic leadership in this space. Really empowered us, Choosing Wisely clinical leads, to do what we do, and also I wanted to highlight. I did mention about resourcing a clinician to be a clinical lead in these Choosing Wisely programs, but also resourcing a project manager to actually support the clinical lead. And the recipe for success is the combination of those two and the combination of those interdisciplinary groups. And then what's the recipe of success in terms of getting this out nationally? And we think absolutely the discussions has been with sustainable QI, quality improvement, because every hospital has to do that as part of the national standards. And by inputting into something that's already resourced and aligning those objectives of sustainable care, good clinical care, with that's very important. So the real lesson to learn, that we've learned, is that you need that executive buy-in, you need that executive sponsor, and also you need to make it obvious that what you're doing is for sustainability. And so our next step is with that carbon footprinting, where our clinical costing unit is linking with the NHS, so that we hopefully get a live dashboard of that in addition to the tests. So it would be lovely to see, hey, look how much pollution, look how much CO2 equivalents that you're saving, look how many cars you're taking off the road. Elon Musk and BYD can take off about 180,000 cars off the road, but and there's about 20 million cars off the road at the moment. We've got the power with Choosing Wisely to take 5 million cars off the road. That's our impact. We've got more power than Elon Musk and China and BYD combined. Thanks.
Wow. Can you just say it again, because I think that should be a snippet that we might get onto social media, and people might, because that's a really powerful, these kind of messages that people understand. So wonderful.
Yeah, absolutely. So there's about 20 million cars on the Australian roads at the moment. Last time I checked, there was about 120,000 or so cars on the road which are electric, and obviously increasing, which is fantastic, thanks to electrification of our cars. But for Choosing Wisely and cutting that 40% of healthcare that is unnecessary and even harmful, which we've shown can happen with the right resourcing, we're taking 5 million cars off the road. So yeah. Wow.
Fantastic.
Incredible.
Thank you, Chris. And Chris, I might ask you there's a question in from Rachel to saying that you might put an answer in the chat about the inclusion of access to digital shared health records, if you're able to answer, Rachel, and that would be wonderful. Move on to Kimberley Walters. I mean, amazing period of time. I'd invite the other members of the team, just if they wanted to ask Kimberley, because I've got extreme bias with pathology and it's such an area. But is there anything that any of the other people on the presenter chat want to ask? We don't have a specific question for you that I can see. There's probably some in the discussion forum, but I suppose the key learnings to get it out there is to coordinate strategically, and we've covered a lot of the things around funding. Tell us something special that's happening in your that you think that we should get out to other hospitals.
Okay, so I did actually see one chat in the earlier,
yeah,
and I think so I did want to say, yeah, the research article that I based the CAHA distances on was the one by Scott McAllister. So good pick up in the chat, whoever posted that. Thank you. And yeah, I suppose fundamentally, I mean, the key learning for me is always that we have a huge number of teams in the hospital, and we just need to let experts lead. I don't know. I feel like that question's very broad. So yeah.
I think it's an important answer. You're talking about autonomy, empowering clinicians, and giving them that space and platform to, that support from the executive to get on with it. Because I know a lot of colleagues that I've worked with were their phrase was banging their heads up against the wall up until recent years. And I think the wall has moved away, our heads, but we're certainly getting more impact. Thank you, Kimberley. On purposes of time, we might go to our next speaker, who was Jenny. And Jenny, you spoke around virtual visits in Hunter, New England. Listen, I've seen patients come down from Coffs Harbour and other areas. I'm sure the same thing happens in all hospitals, where you'd really ask, could this have the care have been given virtually, and did they really need to go? And we kind of talked about it earlier in the earlier question, but getting that message, up to our executives and down to our clinicians is going to be so important, isn't it?
Yeah, absolutely. And I think people understand the non-admitted or the outpatient opportunities, but I think there's a lot more we can do, and particularly with your district as well. But patients that are being transferred around unnecessarily, I would like to see every patient before they're transferred to have a virtual review to confirm that actually that transfer is needed, because an awful lot of patients are transferred around. Not that they don't need that care or that specialist input, but I believe that a lot of that could be provided virtually to keep them at home. So yes, I agree. It's around definitely executive input. Is nothing happens unless it's driven from the top, and getting their input to really drive it. And we don't really like KPIs to work towards, but sometimes that is actually what is the driver and helps us. We always try and keep the patient at the centre, but actually if we're saying we've got KPIs that we need to move, does sometimes, but having the benefit of being, there are so many benefits from virtual care, from the patient to the environment to the cost to clinicians' time. Yeah. So it's a fairly easy sell, but yeah, executive drive is important.
Great, thank you, Jenny. And that segues very nicely. And you were mentioning about the executive. We mentioned from Kimberley's point earlier about supporting and empowering, because I think you're all sparks in your organizations, and it's been able to the journey of what you've learned to get to this position, because we're all a bit senior and helping the other sparks in the system, that they're able to grow as well. So that brings us over. We've got a question in the chat from Rachel Desane, if I'm getting the pronunciation right, and it's for the panelists, and I'm going to go to Alex on this one. It talks about, have you involved designers in your projects? A lot of what's being discussed is systems design thinking and behavioral economic changes. So big design can provide some really great expertise to support this work. And I think that's a really nice question, because I was impressed with all of the slides and of all the speakers, but with yours, Alex, I was really impressed with the lateral thinking and where your brain has gone into so many different areas outside of medicine in terms of psychology and systems thinking, etc. So yeah, what do you think about this question from Rachel about involving designers in projects that obviously that have to know the insides of the systems and the economics, as she mentioned? Yeah, that was to Alex, I think. Can you hear? Yeah, sorry. And then I think Mike's got his hand up, so you want to mention something after, Mike? Thank you.
I've just unmuted. Can you hear me now? Right. Hopefully you can hear me. You can look at that both ways. We'd love to have a designer who would say, yeah, I can help you with your project. That's the problem. We're fairly esoteric. We're small. We haven't got a budget for a designer. But it would be great to have somebody with that kind of skill set coming in and working in the team. Equally, the stuff that we've got has come from broader sources. Sort of online courses and so on, which are also helpful. I think, of all the things I've seen today, the thing that has impressed me most design-wise has been Kimberley slides. They were beautiful slides. And I've had an interest in slides for 30 years, and my jaw dropped when I saw your slides. So thank you for showing us just nice work and design today. So it was great. And so yeah, design is so important, and it really is. There are two kind of other psychological things. There's some people who like to simplify things, and some people who like to sort of magnify things. And so the simplifiers are the designers. They build things right down to their absolute core. The quote from Michelangelo making that statue, David, how did you make it? I took away everything that wasn't David. So you're just taking it down to it. What are the absolute elements that can't be done without, and then start from there. And then the multipliers will take it, nationwide.
Beautiful. Excellent. Thank you. So I hear the simplicity in visuals, and bringing in non-medics, nurses, executives, data people, and designers, the comms team locally, really important. Mike, do you want to, you had your hand up? We're going to go to you, and then we'll finish off with CAHs, as we're just about out of time, but we're getting there. So well done, everybody.
Yeah, thanks. I think Rachel might also have been asking about taking a system-oriented approach, which is what we really tried to do working with the Deakin Globe team, using some software called Sticky they designed, and that allowed this multidisciplinary stakeholder group to actually try and create the system in real time. And we could actually, so that map you saw there, they were able to create that map during the process and then say, does this reflect the system as you understand it? And what are the connections? And how does this increase this? How does this decrease this? And particularly for visual people, that was really, really helpful. And it seemed to help with engagement. Yeah, thanks.
Thank you, Mike. So Kaz, we're going to go to yourself in the last minute or two. And there's so much data coming in. I'm not sure about a specific question, but I know, with regard to nitrous, we know that the carbon hotspots, or, Mike was talking about inhalers, you're talking about nitrous. These are major areas we can, not necessarily quick wins, but we can make really impactful wins across our system from carbon hotspot. So I think people find it difficult to measure and to get to get this first steps running. So is there any tips that you'd give to somebody out there who wants to follow your footsteps? Obviously, you and I and a few others are looking at a nationally strategically organized team. Is there any other final comments you want to make from what you've heard today?
No, I think the first step is to just reiterate that these are all big picture team concepts that we can try and go it alone, but it's much easier when you've got other people pitching in and helping point out the flaws in the plan. I could not do a fraction of what I do without the committed engineers, biomedical engineers, nurses, the support of the department. None of this would be possible without operating in a team environment.
Yeah, that's a very important point to end on, and I think it is. You can see the team that we've got here, and the breadth of all the different disciplines. So I'd like to finish on that, and I'd also like to say, we're all in different states, and we can pivot around the new National Health, Sustainability and Climate Unit. I met Madeline Scalern and Georgia and many of the team, and it's wonderful we have that national unit. I think we need to leverage towards that national approach with DEA, with CAHA. I mean, this is a wonderful forum with GGH, linking together and pivoting up nationally and giving our resources and then spreading that down again nationally through our regions would be wonderful. So as we're about to sign off, I just wanted to thank all our presenters today for generously sharing your stories and your experiences. It brings us to the end of this session and the end of a massive week with this forum. You'll notice a button that reads Event Stream. This is an app platform that allows you to post an update or an image and respond to others. So please feel free to post. And if you're holding a group viewing session, we'd love to see your setup. So don't forget the meeting hub that provides an opportunity to connect with other attendees in the lobby after this. And now you can stay on for a few moments while we mingle with other attendees and presenters for the next 20 minutes. And next up in the programme, you'll see on Tuesday, we'll have a wonderful lineup on caring for country, and we hope to see you there. So I will be online. I just have to take an urgent call, but I will jump back on in a few moments. I want to thank everybody, especially to the CAHA team, being led by Michelle Isles as our CEO, Leung as our president, and Steph, and all of the team who've been really working so hard. So thank you so much to everybody, and Glenn in the background for solving all our tech issues. It's been wonderful to have you, and we're looking forward to the next sessions and looking forward to meeting people who've connected through these meetings and getting this. We're really building a massive wave across Australia. So thank you very much, everybody, and we'll see people in the networking in a moment. Thank you.